welcoming Dr. Jade.
Thank you. Thank you all so much for having me. We're just getting set up. All right. So the topic today is I shall live and not die. I got to hear a little bit before I came in, and it sounds like we're already in the spirit of wellness, already in the spirit of thinking about our hobbies and about how we can pour into ourselves. That's what I'm all about. So I'm excited to be a part as well. Thank you so much for having me. So let's talk about some women's wellness, yeah? All right, so a little bit about me. I am Dr. Jade Norris. Thank you for the kind introduction. I'm a board-certified family medicine physician. I'm certified in obesity medicine. I own a private practice here in Las Vegas called Inspire Primary Care. I'm a wife and a mommy of 2 little girls, wellness advocate in our community here, and a children's book author. A little bit about my journey, because people say to me, how did this all happen? You look 5, you look 20 years old. What happened? And this is a little bit of my timeline journey. I've been saying I wanted to be a physician since I was 4 years old. Everyone would ask, what do you want to be when you grow up? And I would say, I'm going to be a doctor. And they would look at this little girl from Chicago who no one in their family was a doctor. And they'd say, oh, that's a cute dream, you know? But that's what God showed me. And I stayed committed to what he showed me. Then we transitioned into medical school, difficult journey to get on in, but God made a way. Then residency, we had 2 children during residency. And then 8 weeks after I had my second baby, we opened our private practice. There's us at the top at our ribbon cutting, putting the sign up on our door. And then this is kind of what everyone sees today. They didn't see the 15-year struggle to get there. But Instagram, they see Dr. Jade MD. But this was really the journey to get there. Okay, our agenda for today. So we're going to talk about essential health screenings. Everybody have a sheet in front of them? Everyone has that? I guess they have a mic for me. I wasn't using it. Does it sound better with the mic? Let's see. The mic is, let's see, testing. Is that better?
Yes.
Perfect. Okay. All right, so we got the mic. And all right, here's our agenda. I like for people to know where we're going. So we have our essential health screenings. Anyone in here in medicine or healthcare? Just checking the audience. Okay, perfect. So what I share hopefully will be some new things and build upon what you already know about health and wellness. I'm a primary care physician, so we're going to infuse that with wellness today. All right, we're going to talk about essential annual labs. We're going to talk about some essential vital signs. We're going to talk about wellness goals. This is what I love to talk about. The Inspired Health Method is my trademarked wellness method that we do in my private practice. We're going to talk about one of my favorite topics, which is boundaries and balance. And then my favorite, I say everything is my favorite, but also my favorite is joy in the journey, because we're not doing all this and accomplishing all this to be miserable. It really is about joy in the journey. So how do we do that? And I'll show you some ways I've done that and how I help my patients try to accomplish this as well. So this is what the front and back of your sheets look like. We'll be starting with the front. So you guys will want the health checkup component on the front. I like to make these interactive. It will be workshop style, okay? Everyone have a pen too? All right, perfect. So we got our pen. We want the health checkup, the pink side upward, all right? And then we'll just put check marks as we go through the different sections. We're going to make it interactive. I'm going to ask you some questions, so just throw those answers out there. And then the back will really be our implementation. And this one, don't feel pressured to complete here. It really is more about being thought-provoking, and it might be something you want to take and complete on your own with more time. So here we go. Let's start with essential health screenings. All right, so I'm going to put on my doctor. I could geek out on this stuff, all right? So I want to know what you know, because for me, I do this every day, and I forget, what do people know? What do they not know? What questions do they have? And so I want to know what you guys know. We're going to look at that health screenings box. On the next slide will be the correct answers. On this slide, we're going to shout out what we think the answer is, all right, so we can really see what do all these screenings mean? When do we get them? How often should we get them? This is really, really important. So are you up to date is the question. The first thing is our pap smear. First of all, who knows what a pap smear screens for? I heard cancer. I heard cervical cancer. Exactly. A pap smear screens for cervical cancer. Here at the top left, you'll see we do a cervical cancer brush, a screening brush. It just gently removes some of the cells of the cervix. We send that off to the pathologist at the lab. That's a front view of what our cervix looks like, kind of looks like a donut. The reason that brush is shaped where it's pointier at the end is because we're getting the exocervical cells, the outer cervical cells, and then we're also getting a little bit of the inner cervical cells because both can become cancerous. So when you start to be 21 years old, I think all of us meet those guidelines. 21 years old or over, that's when you start getting a pap smear, regardless if you're sexually active or not. That is when cervical cancer can and should start to be screened because that's when cervical cancer is in the process where it can be detected, okay? But before 21 years old, typically, cervical cancer has not yet developed, okay? So that's why we start screening at 21 years old. How often should we be getting a pap smear?
Every year.
Okay, I heard every year. I heard every 2 years. Every 10 years. Any other thoughts? These are excellent. Okay, we're going to put a pin on it. We're going to answer it on the next slide, so that's excellent. And there's a reason there's variation in the guidelines. We'll talk about it. Or in what you guys just said, there's a reason there's variation in that, so we'll talk about that, all right? And then at 45 years old, some of us meet those guidelines. When you hit 45 years or older, we should start getting our mammogram. Now, this is a blanket statement. Guidelines actually say that mammogram screening should start at 50 years old. First of all, what does mammogram screen for? Okay, yes, mammogram screen for breast cancer. So the guidelines actually say to start screening at 50 years old now. But we want to look at our first degree relatives. We want to, if any of your first degree relatives, meaning your sister, daughter, mother, and we also look at grandmother had breast cancer, then those guidelines will shift downward, okay? And depending on what decade of life or age that they were diagnosed will help your doctor to recommend when you should get your screening. But as a blanket statement, the guideline says start screening at 50. However, we know that many women, especially Black women, we're finding more cancers between the age of 40 and 50. So I, in my practice, shift starting at least in this, as a blanket statement. It may be earlier depending on their personal family history. 45. I shift screening about 5 years earlier for our patients, which goes right at the same time where we start their colonoscopy screening. So it's just a nice way to say we're 45, let's start those mammogram screenings, let's start those colonoscopies. All right? But talk to your doctor. All of this, you want to talk to your doctor because we still need to know your personal history, your surgical history, your family history, your symptoms. But these are the general health screening guidelines. You working with me? You got it? Yeah. Okay, so how often should we be getting a mammogram? Every year? Any other thoughts? Every 5 years? So, okay, perfect. This is some good variation, so we'll talk about it. There's some reason for that variation, too. We'll talk about it on the next slide. All right, and then colonoscopies. What do colonoscopies screen for? Colon cancer, exactly. Again, blanket statement is that screening should start at 45 years old. Old guidelines said that it should start at 50 years old. Then we started seeing that we were misdiagnosing or diagnosing people too late with colon cancer if we waited until 50. So now guidelines say you should start screening at 45. This is still a blanket statement because, again, we're all individuals. Things that increase your risk of colon cancer even younger than this is going to be a history of tobacco use, history of alcohol use, and also obesity. So again, 45 is at least, but you want to talk to your doctor to see if that recommendation should be shifted earlier. Also, if you've had any history of blood in the stool. These are all reasons you might get screened earlier. So how often should we be getting a colonoscopy? 5 years. I heard 10 years. I heard 5 to 10. Any other thoughts? Down to 3. Okay, some variation. There's a reason for that. This is why it's so confusing to people. This is why they're like, well, TikTok said this, and then YouTube said that, and then Google said this. So we'll talk about it. We'll talk about it on the next slide. And then this one isn't talked about as much. What do you guys know about a DEXA screening? This should start at 65 years old. Anybody familiar with that? Okay, I heard no, not familiar. I heard bone scan over here. Excellent. What is the bone scan looking for? That's correct. Density of the bone to diagnose what? Oh, yes. Okay. Ding, 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 ding. Perfect. It's osteoporosis screening. Excellent. And so that should start at 65 years old. Again, this could shift earlier depending on your history. If you're very frail, very thin, if your mother or grandmother had a history of osteoporosis, if you've had a history of hip fractures, then you may need to be screened earlier for a DEXA scan. But the blanket statement is 65 years old. Excellent. All right. I got the cheat screen for you here. We had the colon over there, the breast over here, the bone over there. So there we go. Okay, let's go to the answers. All right, so you will see a variation, and let's talk about it. Pap smears, starting at 21, should be every 1 to 5 years. So what's the 1 to 5 years? Now, there is guidelines. This is why it's confusing. This is why you should always talk to your doctor. It's a combination of your history, also what your doctor has seen in their training, also how your doctor was trained, mixed with what the guidelines say. All of that combination will be shifting how often your doctor will recommend these screenings for you, okay? So I say every 1 to 5 years because guidelines say that if you get a pap smear and the pap smear, meaning the cells, the cytology, the cells were normal, there was no cancerous cells, and then we also test for something called HPV, human papillomavirus. That's the virus that most commonly leads to cervical cancer. So if the HPV is negative and the cells are normal, then guidelines say that you can start screening every 5 years. That's if you're over the age of 30. If you're under the age of 30, between 21 and 30, 21 and 29, then guidelines say every 3 years. If you're over 30 and it's normal and the HPV is negative, guidelines say you can wait 5 years. Now, that's guidelines. However, there's clinical practice. Clinical practice will show you that although guidelines say you can wait 5 years, many women's cancers, I shouldn't say many, when you look at the population, it's rare to find that cancer has developed sooner than 5 years. That is why the screening recommendation is every 5 years, because it is a slower growing cancer where it's unlikely to find cancer if you screen more frequently than 5 years, okay? However, we're not a textbook. We're all individuals. We're all humans. Our risk factor is different, and sometimes cancer grows fast, and it may be a rare population. But there are some people where if you wait 5 years, a cancer has developed and it's too late, and all there is, you know, you're about to pass away. It's rare, but that's why clinical practice, you will still see physicians that recommend get the pap smear done every year. Okay, so that's why there's this 1 to 5 year, because guidelines say 3 years if you're 21 to 29, 5 years if you're over 30 and it's normal, but then your doctor might say, well, I've diagnosed cervical cancer in women who waited 5 years, so I recommend for you to get it done every year. Does that make sense? So in my practice, I recommend every year. It's very uncomfortable for women, if they are just having so much anxiety about it, it's a really uncomfortable exam for them, they're like just can't tolerate doing it every year, then I just say as frequently as you can tolerate, but I recommend every year. Okay? We tracking? All right, there will be time for questions, and if you have questions along the way, please feel free. All right, mammogram screening. So every 1 to 2 years, same thing, you guys, same thing. Guidelines say you can wait up to 2 years to get that mammogram screening. However, sometimes breast cancer grows fast, although it's a smaller percentage in comparison to the population. It can happen where we find someone has waited 2 years and now they are stage 2 or stage 3 breast cancer where it could have been stage 1 had they been screened every year. So your doctor may recommend, and most radiologists at the imaging centers, all of the reports when I get them back, they all say recommend screening next year. Now some people say that, oh, they just want to make more money because if they get them done every year instead of every 2 years, that's a better money generator, but it still decreases the risk of us finding cancer later. So I recommend annual breast cancer screening to my patients. Again, unless they're like, it hurts so bad, I can't do that every year, then I'll say, okay, every 2 years. But the recommendation for me as a clinician is every year if you can tolerate it, okay? Earlier we find cancer, the better our risks of it going into remission, all right? Of these screenable cancers. Yes, ma'am?
Oh, I was just going to say, too, that it's important that you do your own self-breast exam, because that's how I found my cancer.
Absolutely, and so I get asked about that. We don't do breast cancer or breast palpitations as much in our office simply because I'm going to send you to get the picture, right? I'm going to send you to get the mammogram, but you on your own, absolutely. I recommend, and some women will take this to the extreme where they're in the shower every day feeling for breast cancer. And I tell people you don't necessarily need to do it that frequently. When you're in the shower, when the water is slick, one hand up, gentle circles around the breast. And what I'm really trying to get women to see, and I say, do it every few months. And what we're really looking for is for us to know what our normal tissue feels like. That's what this is all about. What does your normal feel like on both sides? That way, if something all of a sudden feels completely different from your normal, then you bring it up to your doctor. Otherwise, staying up to date on your screenings, yes.
And I highlight what Mom said and a little earlier.
Mm-hmm.
My daughter at age 16 self-diagnosed breast cancer.
Wow.
And had to have three, thank Jesus, they were removed.
Wow.
And even surgically, given her age, the way they went in, they were cognizant that she was going to be a mother at some point, want to breastfeed. But
Yeah.
at 16, that just blew me. And
Yeah.
for her, we talk, you should do these things, but even earlier, young persons having
Yes.
self-examinations.
Absolutely. And we never would tell a teenager to start, checking their breasts because according to the textbooks, we really shouldn't start worrying about this till around our 5th decade of life, but we are individuals. We're not a textbook, which is why being our own advocate is really important.
What are your recommendations for doing is it BRCA, the screening to see if you have the gene? Is that part of this?
Yeah, as far as BRCA screening, it really is recommended to screen for that if your first-degree relatives, multiple first-degree relatives, had breast cancer. So it's one of those things. All of this, when it comes to medicine, is weighing the risks versus benefits because say none of your first-degree relatives had BRCA or had breast cancer, but then you test and you have the BRCA gene, now you're freaking out. Now you may still never develop breast cancer, but now you have this gene. Now you might get your breasts removed, even though you don't need them removed. So it could create more anxiety that you don't need. So all of this is weighing the pros and cons, the benefits, what will give you peace, what will make you feel like you're, doing your due diligence, but also not excessively worrying. Yeah, so I don't recommend BRCA screening to patients unless they've had multiple relatives with first-degree relatives with breast cancer. But it's all about peace of mind too. But I have some patients that come in and say, I want all the cancer screenings. I want all the blood work. I want head to toe. I want the MRI. And I'm like, okay. And then we do it. And then something is slightly outside the normal range. And I'm like, well, we don't need to do anything. You're just going to worry about that now. But there's nothing for me to do about that. So weighing that is important. Okay, these are excellent questions. Excellent questions. Yes.
So I'm always curious when we see health screenings that there's nothing on there about dental health.
Yes.
Have you considered that? Is that something you talk to your patients about? Because I think it's equally important, but because I feel like it's because insurance doesn't cover dental care, a lot of dental care. But it seems like that's a source of being proactive as well.
Absolutely. So what I do in my office, I have something called an onboarding appointment where I'm basically finding out everything I can find out about them in my practice, right? And a part of that, one of my questions I ask is, are you established with a good dentist? And then they'll tell me yes or no. If they tell me no, I have a list of recommended dentists and I plug them in with them. That's because I don't know nothing about the teeth, and I don't want to know nothing about the teeth. And so truly it's about getting you established with a quality dentist. So if you have tooth pain or if you need to be up to date on how to properly screen for your dental health, that truly is nothing we're taught about that in medical school. So I let them know, you have teeth pain, please call your dentist. Please stay up to date on your health screenings or with your dental procedures. At least every 6 months is the recommendation, but maybe that might need to be more frequent too, depending on their dental health, right? So it's a whole different set of tools. I do the same thing with optometry. I ask, are you up to date on your screenings with your eye doctor? Again, if you start, of course, if you're having eye pain, I'm gonna tell you to go to the emergency room. If you start having vision loss, I'm gonna tell you to go to the emergency room, but otherwise, eye health is really outside of the scope of primary care. So that's why we have optometry. So yeah, it's screening for those and making sure they're well established with those. Absolutely. Yes.
I was meant to ask this a minute ago and I got into it, so thank you. When you were talking about the pap smear, are there variations in terms of recommendations if you had hysterectomy? Because I think that that's oftentimes something that's not discussed as well.
This is a great question. And it's not discussed as much because there is a lot of variation in the recommendation depending on your doctor, and the guidelines are also fuzzy and gray area on it. So a hysterectomy is a removal of the uterus, okay? So up here at the top, the round bowling ball looking component, that's our uterus, right? But at the bottom where the brush is, we're screening for the cervix, the cervical cancer. And then on the outside, we have those fallopian tubes, and the ovaries are those egg-looking things, right? So what's happening is surgically, your doctor is cutting those fallopian tubes and removing your uterus. 95% of the time, I'm not a surgeon, but I'm well-versed in OB-GYN, okay? And so 95% of the time, because the cervix is attached to the uterus, when they remove your uterus for a hysterectomy, the cervix typically gets removed as well, okay, because they're attached. However, if you were getting your uterus removed because you had something, for example, like endometriosis, where there's a lot of scarring, there's a lot of scar tissue, sometimes they can't get all of the cervix removed, and there may be partial or the full cervix left behind. So it's very important, and I ask my patients this question, and a lot of times they have no idea. I'm like, do you still have a cervix? And they're like, oh, nobody's ever asked me that. I don't know. And I'm like, so we need to either get the cervical or the hysterectomy report, or let me take a look and see if there's a cervix present. Now, so that's if the cervix was removed or not. That's a full hysterectomy. And when we talk about total versus partial, partial just means that the ovaries were left behind, okay? And that's so you don't go straight into menopause. Sometimes those are taken with us, sometimes those are left behind, and there's many reasons to why they may be taken or left behind. So the main thing to know is your cervix still present? And then some people's cervix is completely removed, but again, there are very rare cases where although the cervix, the organ, right, was removed, however, some of the microscopic cervical cells may still be present in a woman's body. And so some OB-GYNs may still say, although your cervix was removed in addition to your uterus, I still like to do what they call a vaginal cuff PAP, where they're still just throwing the brush at the top of where the cervix used to be, which is now just the surgical vaginal cuff, just in case there are any cervical cells left there that could become cancerous. It's very rare, and some OB-GYNs do not do vaginal PAPs. So that, again, will be personalized. That's why it's hard to get this information off the internet. And that's why I tell people, please establish care with a quality physician that will really take the time and talk with you, because every single thing, although there's a blanket statement recommendation, there's so many, there's a lot of fine print that's individualized to the individual, okay? Even if you surgically remove, right? So I have people surgically remove, you remove everything, including the ovaries, that puts you into menopause, and then they come to me and they say, oh, Dr. Jade, I got hot flashes. And then they want hormone replacement therapy, which is high-dose estrogen, and you just should have left your ovaries, because now we're giving you the same cancer risk by giving you high-dose estrogen for your hot flashes. So it's a lot of balance. Got to talk to your doctor, but these are important things. That's what I'm saying. It's all pros and cons and a lot of minutia. All right, these are excellent discussion points. All right, colon cancer, 45 years old. We start the screening, it's every 3 to 10 years. Now, I threw this every 3 to 10 because the blanket statement is if you get a colonoscopy starting at 45 years old and it is normal, then your normal meaning no or just very few normal benign polyps, okay? Then your GI specialist, your gastroenterologist, should tell you to come back every 10 years. Now, depending on how many polyps they may have removed, and they will send those off to pathology to look at them microscopically to see what stage of cancer, although it may not have been in a malignant state, they could be kind of like a gray area polyp, okay, where it wasn't completely normal, but it wasn't full-blown cancerous. And so they may tell you to come back more frequently, okay? They may say, all right, it wasn't cancer, but we removed some polyps, or we removed a polyp that was not completely benign, come back every 5 years. Or they may say, come back every 3 years, okay? It all depends on how many polyps they found and what those polyps looked like under the microscope. Everything completely normal, it's an every 10-year screening. The other thing that I put 3 to 10 years was because there's something called so there's colonoscopy, where they look at the walls of the colon. They put you under anesthesia, they look at the walls of the colon, and it's diagnostic and therapeutic, where they can remove the polyps as they see them real time, okay? That's why it's the most accurate, 99.9% accuracy, okay? The 0.1 because the doctor is still a human, all right? But that's the most accurate. But then some people are like, I don't want to go under anesthesia. I'm a low-risk cancer person. We can talk about what that means. Are there any other other options besides doing that. And so maybe you've heard of Cologuard. Anybody heard of Cologuard? It's the box. You've seen the commercial, the box they send to your house and you put the poop sample, the fecal sample in there and mail it back to them. And then what they're basically looking at is for microscopic blood in that sample. And so if there's no microscopic blood, that's a normal screening for Cologuard, and that is a every 3-year test, okay? If that comes back positive with any blood found in that, then you still have to get a colonoscopy, all right? All right, any questions about that? All right, and last is the DEXA scan. And that one starts screening at 65. It's a lot of gray area with this because basically we're looking at longevity more so than health. These other ones are cancers where they can kill you if we don't diagnose them early, versus the DEXA scan with osteoporosis is really looking at longevity and aging well. So some people don't hear about it as much because it's not screening for cancer, it's more so screening for the fragility and making sure you're safe and aging well and that you have that bone health so that you're not falling and breaking your hip and then all of a sudden having passing away very early due to poor quality of life with mobility. So that's what that one's screening more for, and because of that, there's a gray area on the frequency. Guidelines don't say how frequent to screen for it. It says patient-physician decision-making, and that's based on what the DEXA results were, okay? Because it can be completely normal, it can be a gray area of bone health called osteopenia, or it can be a poor area of bone health called osteoporosis. So it depends on where we are on that spectrum, okay? I have some patients that have osteopenia, and then I'll say, let's do this screening next year just to make sure we're not rapidly going towards osteoporosis. So, for example, vitamin D, a good supplement, women's supplement, calcium, and resistance training. Those are really the things we can do to help our bone health. Yes?
Will you be talking about vaccines?
I will not be talking about vaccines. You have a vaccine question?
About the shingles vaccine?
That's good.
Something that you recommend to your patients?
So vaccines are a hot topic. I don't go over them because it's really a lot of patient preference, and the recommendation is pretty individualized. I basically tell people the age-related guideline on when guidelines say you should get a screening for that, so 50 years old. So when my patient is 50 years old or over, I say, guidelines say that you should get a shingles vaccine. If you would like one? Yeah, there's a lot of variation in that. The main thing I'm asking about is if patients have concerns about their memory. Typically, patients will bring it up to me if they have concerns about their memory. They're starting to forget names, they're starting to lose things more frequently, especially if they can't remember their way home. There's people that they ran into that they used to know well and they couldn't recall their name. People usually will bring it up to me, and then there's a screening in our office called a MOCA that I can do, which is the MOCA, and I can do that screening, and depending on the scoring on that, it takes maybe 10 minutes in our office, then I can refer them to neurology to get a more in-depth neurological workup. There's also lab work I can do that are memory related, so like vitamin B12, folate, iron deficiency, anemia, some of those things can fog the memory as well. So I'll do the health screenings in the office with lab work and the MOCA, and then from there, I'll plug them into the appropriate referrals if needed. Excellent question, yes.
So when you do your mammogram, I'm told that I have dense breast tissue.
Yes.
I have a concern for dense breast tissue. Maybe you can help me with that, because one time they said they found a lump and I had to wait 6 months. That is the worst 6 months waiting period I ever had in my life, because I'm like, I could be dead in 6 months if this is cancer, depending on what type of cancer.
Mm-hmm.
And I've had my great aunt and my great grandmother pass from cancer.
Mm-hmm.
And so, no one in my immediate family has cancer or died from cancer, but it still, it irks me to have to wait 6 months.
Yeah.
And so, when they went back, the lump supposedly disappeared.
Yeah.
But I have this tissue,
Mm-hmm.
and it's like, what do you do? And then I watched a documentary where there was a lady who had yeast tissue and she died because they failed to diagnose her.
Mm-hmm.
So what is your recommendation for women with this issue?
That's a good question. What the mammogram is doing is it is called a screening test because it doesn't diagnose. It gives us a picture of if there could be something present. So imagine like the old school black and white movies where you could see, but it's not the HD TV view that we have today, okay? grays and blacks and shadows. And what they're doing is they're using the machine to look through the breast tissue to see if there are any shadows of a mass. And if there is a shadow of a mass, what does that mass look like? Does it just have smooth edges? That's more of a benign appearing. That could be a cyst or just a benign lump. Or does it have curved or asymmetrical edges, which is more concerning for something cancerous? So they're not only trying to look through the tissue, like with a flashlight through this tissue, is there something there in the shadows? So what happens is dense breast tissue, you can think of it like clouds, right? Like cloudiness. It makes the picture more hard to see through the tissue. This is why they recommend for you to start screening at 50, because when we're younger women, in our second decade of life, third decade of life, the tissue is more dense the younger you are. As you get older, fifth decade of life, the tissue starts to become less dense where you can actually see through to see if there's a mass there. Okay, so if we start screening women in their 20s and 30s, we're going to be looking at a whole bunch of dense breasts, and then it's going to be a whole lot of false positives, and maybe there's something there, maybe it's not. Let's do more testing, which leads down a more expensive road, and you never had to test anyway because everyone's tissues are dense, 20s, 30s, and it just naturally thins out. That's part of how God made us. So to answer your question is, yes, it can be frustrating to have to wait that 6 months, but if they did it more frequently, they may not find a different answer in between that time. And it's not ethical to tell someone to come back more frequently if you have a low likelihood of finding the answer, the correct answer, if they screen sooner. Does that make sense? Doesn't take away the frustration or the fear or the worry, but it does at least help you understand what they're looking for and why they're recommending that time frame. And same thing with blood work. Say the blood work comes back to me and someone's pre-diabetic, right? We do a hemoglobin A1C. We'll talk about lab work in a moment. And they're pre-diabetic, and they're like, well, I want to get my blood done next month and see if I've improved because I stopped drinking soda, and I want to see if that shifted things. And I'm like, well, actually, the test is an average of your blood sugars over the course of 3 months, so it's not accurate if I screen for it sooner than 3 months. So let's repeat that hemoglobin A1C in 3 months. Now, they don't want to wait 3 months to see if it has transitioned towards diabetes or if it's reversed towards normal blood sugars. But it's not an accurate test if I recommend doing it any sooner. Okay? Hopefully that can translate as to why that screening is there with that frequency. Okay? Excellent questions. Excellent questions. So that transitions us to lab work. I want you just on your paper, though, to put a check mark next to each one. This is your own personal. We're taking this away as your health checkup, okay? Put a check mark with the ones you're up to date. So if you are up to date on your pap smear, put a check mark next to that dot. If you're up to date on your mammogram, put a check mark. If you're up to date on the colonoscopy, put a check mark. If you're up to date on your DEXA, put a check mark if you're not 65 yet. But if you're over 65 and you've done a DEXA, put a check mark, okay? That allows you to go away with this saying, okay, where am I on my healthcare screenings?
One last question.
Yeah.
Pap smears after a certain age, I don't know if it's 50
Ah.
or whatever, they started changing.
When to
And I'm
stop
like,
screening.
I'm getting mine every year. They're
Yes.
Like, yeah, no, you don't have to. I'm like, I want mine every year. I've
Yes.
been here since 21. We ain't gonna stop it now.
Yes, that's excellent. That's an excellent question, you guys. I love these. So yes, the screening is to screen from 21 to 65. Again, a blanket statement of how long we should screen. Colonoscopies also have a cutoff of 65. Some GI specialists cut off at 70. Now, does that mean our life stops at that age? No. The whole idea here is it's patient-physician decision-making after that age, okay? And what that means is if cancer was diagnosed at 67, how much would you want to do to preserve your life, okay? And the whole idea here is if we diagnose someone of cervical cancer, truly the only thing we have to do is surgeries, chemo, radiation. And so the idea is it worth continuing to screen after 65 when the only thing we have to treat it with will not preserve their life further?
They told
That
me
again
I
is a
was
blanket
50
statement.
Because I had been moving along so well, and I'm like, what the hell? I'm like,
Yeah, guidelines is 65. Everything with physicians is going to vary. So a lot of this is know what the guidelines say, find a physician you trust, and have those good discussions on how to personalize the guidelines to your individual health. Like, that's really what this is about, yeah. And so, although you can stop screening if you want to stop screening, because you're like, at this point, I'm not going to be letting you cut on me, do this, do that. You know, when God calls me to go, I'm gonna go at this point. Or if you're like, I have a whole lot more life to live, 65, I've got till 105. Like, I still will do whatever is necessary to try to fight this. Then that's when you say, I want to continue PAP screenings. Yeah. All right. So what do you guys know? Oh, I think my clicker cut out on me.
I have a question.
Yes.
So if you are not sexually active, you still receive pap smears?
Yes. Yep. And that is because we are not screening for sexually transmitted infections. We're screening for cervical cancer. Very good question. A lot of people confuse pelvic exams with a pap smear. A pelvic exam is just when your doctor is looking at the vagina and taking that speculum that none of us like and look inside. It's just an exam. That's a pelvic exam. Just because I looked does not mean I did a pap smear. Unless I took that brush, collected cervical cells, sent it off to a lab, a pathologist looked at the cells under a microscope, gave me a report and says non-cancerous, then we did not do a pap smear. Okay? Pelvic exam versus pap smear. We're good? Okay, perfect. Let me see if it'll let me do it on here. No, it's just frozen up. All right, so let me see. Can I get, Amber, do you have an extra form for me? Because I can shout it out until we get this fixed. Thank you. Perfect. All right, so next, let's go to labs, all right? Annual labs. I want to know what you guys know. What is a CBC? Anybody know? CBC is a complete blood cell count. What is that, and what does it look for? A complete blood cell count, but what is it looking for? White blood cells, red blood cells, differentials. Perfect. Okay, we'll put a pin in it. These are good. These are good. The next one is a complete metabolic panel, CMP, complete metabolic panel. What is that looking for? Okay, looking for sugar, potassium, cholesterol. Okay, this is how we're going over it. No, I love it. I love it. That's why we're going over it. Okay. Okay, perfect. We're going to talk about it. And then the TSH-T4. What is that looking for? I hear heart. What is it? There are no wrong answers. We're going to learn together. Thyroid. Okay. Any other guesses? Ideas? Okay, perfect. So we'll come back to it. Hemoglobin A1C. I gave you a sneak peek of that. What's that looking for? If you're diabetic, blood sugar, okay. And then lipid panel. What is that looking for? Cholesterol. I heard some triglycerides, HDL, LDL. Amazing. And then HIV, that's screening for HIV. So I didn't leave a line there because we know what that is. But these are the annual, again, blanket statement, annual labs that are recommended for every woman. Does that mean it's the only labs you should be getting done every year? People are going to say, well, what about my iron panel? What about my vitamin D? Those are patient-physician decision-making, but guidelines say you should at least be getting these done every year. Okay? All right, so let's talk about what they are. It froze up on me. It was like, she's got to speed this up. Okay, thank you. All right, so the CBC, the complete blood cell count, looks at your complete blood cells, meaning your red blood cells, your white blood cells, your platelets, your immune cells, neutrophils, monocytes, lymphocytes. Those are the different immune cells. Your doctor's really looking for a screening. Again, it's not a detailed test that can tell somebody they have hairy cell leukemia, okay? It's not going to tell you what type of diagnosis. It's a screening to see, could a patient have a type of anemia? Could a patient have an infection? Could a patient have something going on with their immune cells and their immune health? So that's what a screening is. You can think of it like an umbrella, okay? And then if anything's abnormal on the screening, then we go more in depth with either additional blood work or referrals to a specialist. Yes? Yes, the CBC will look at the white blood cell count. It will. There's lots more blood work that can look at these cells in more detail, but in general, yes, it has a white blood cell count. It'll tell you how many, and then depending on how that looks, there's something called the differential, which looks at those cells even more in depth and breaks the types of white blood cells down, which neutrophils is one type, but there's so many other types. So depending on if a certain type is elevated or decreased, then it leads us to a whole different diagnosis. So again, that's why we just generally screen with the CBC of, are the white blood cells elevated? Are they very low? And then if needed, then we do more detailed testing. Yeah, excellent. So that's what our CBC is looking for: anemias, infections, all right? Perfect. Thank you. All right. Battery ran out, no problem. And so then the complete metabolic panel, so you all were right. We're going to flip to the answers now. All right, so we said anemias, infections, immune health. We're looking at electrolytes, okay? So that's looking at the glucose, which is your sugar. We're looking, you guys can write it down, take a picture, but you can write it down on your sheet too. It's looking at your kidney health, all right? The kidney health is gonna be things on there. Oh, perfect, okay. So we're looking at the kidney health, we're looking at the liver health, all right? Those are the main things we're looking for on the complete metabolic panel. The TSH, T4, those are the two things to look at for thyroid health. Thyroid is the gland in the middle of the neck. It controls much of our metabolism, okay? When people tell me they're fatigued, that they're hot, I mean, all these different things, they're having weight gain, I need to know if the thyroid is normal, okay? All right, and then a hemoglobin A1C looks at our blood sugars. I told you it's the average over 3 months, all right? It can tell us normal blood sugars, pre-diabetes or diabetes. One of the things I specialize in my office is helping my patients prevent and reverse chronic diseases, so I help my patients reverse these as well. And then lipid panel looks at cholesterol. It breaks down the total cholesterol, then it breaks down the different types. The LDL and triglycerides you all mentioned, those are two of our unhealthy cholesterols. And then our HDL, you can think H is healthy, that's our type of healthy cholesterol. That comes from things like avocados, nuts, healthy fats, okay? Those are gonna contribute to our healthy cholesterol. Fatty fish like salmon as well, all right? And then HIV, of course, screens for HIV, and I recommend, you know, people are like, I've only been with my husband, you know. You can use your discretion, but it's recommended for sexually active adults annually. And I can't tell you, unfortunately, working in an HIV clinic, how many married people I didn't know that they should have been screened, even if they just were with one partner. Yes?
With that, when you get married, marriage license, when I got married, we screened for that.
Yes.
I think that may or may have stopped, or maybe
Yeah, no.
state specific.
It may be state specific, but it's definitely not in, I got married in Nevada. So it's definitely not Nevada. I trained in California and Illinois. It definitely wasn't a thing in either of those states. Yeah. So I don't think that is a requirement anymore. Yeah. That's excellent. All right, so we're gonna go through this one a little bit quicker. We've got 10 minutes. You guys have such great questions. Vital signs. We're not gonna skip this though, because I love this. All right, so what is a healthy blood pressure? What do you guys think a healthy blood pressure is? 120 over 80, 110 over 70, we'll talk about it. And then healthy weight range. Now, people ask me, what is the healthy weight range? I want you to write on your paper, this is your personal paper, nobody needs to look at your paper, what you believe your healthy weight range is. Now, I'm 5'8", I know my healthy weight range is between 160 and 169. If I'm in the 160s, that's a healthy weight for my body, my frame. Okay, so that's my healthy weight range. It's important for us to know what that is. You guys may be like, well, what is that? I'll talk about it on the next slide. All right, so guidelines. There are two associations that tell us what a healthy blood pressure is. There's the American Heart Association and the JNC8. The JNC8 are our kidney doctors. They deal with high blood pressure or hypertension due to the kidneys failing and dialysis, okay? They say that a healthy blood pressure is the top number, the systolic number being less than 140, the bottom number, the diastolic number being less than 90, all right? But the American Heart Association says, well, there's still too many heart attacks and strokes if we're just doing less than 140. So they say that a healthy blood pressure should be less than 130, all right? And that they agree that the diastolic should be less than 90. So I tell my patients less than 130 over less than 140 over less than 90. Now, lower is better as long as it's not too low, all right? Again, these are things you want to talk to with your doctor because it depends on how frail you are. So if you're very, very petite, then it may be your normal to run in the 90s, low 110s, for that bottom number to run in the 70s. That may be healthy for someone very petite, but that may make someone else pass out, okay? So again, it's a variable. That's our blanket statement of what a healthy blood pressure is, but you want to follow up with your doctor, okay? And no, are you in your healthy weight range? I didn't do this, but on that last sheet, I want you to put a check mark on the ones you are up to date on. If you've gotten these done within the last year, put a check mark next to each one you've done in the last year, okay? This is your health report that we're taking with us. Blood pressure. If you know your blood pressure, you've been checking it, and you believe it's in a healthy blood pressure range, put a check mark, okay? If you have hypertension and you're on medication and it's in a healthy range, put your check mark, all right? If you have not checked your blood pressure, you have no idea what it is, don't put a check mark. That's something for us to look into. Healthy weight range, that's two things. That's the weight range in which we feel our best, okay? We know which weight where we don't have acid reflux, back pain, can't run after the kids, can't bend over, okay? I lost 60 pounds after my second pregnancy, and I had all of those things, so I know what it feels like to be out of my healthy weight range. So the weight range in which we feel our best, okay? And where we have the lowest chronic disease burden, meaning our blood sugar is healthy, our blood pressure is healthy, our cholesterol is healthy. That combination is what I call in my office your healthy weight range. So what does that look like for you? What is that range? Write that number down between this and this. Write it down, okay? And if you're in your healthy weight range, put a check mark.
Jade, I have a question.
Yes.
So when you talk about the healthy weight range, you're not talking about those charts that we see on the internet that says
BMI.
Yeah.
I don't go by BMI alone. I don't. Because it doesn't give us enough information. As we know, some of us are curvy, all right? And those curves may be healthy for our body frame. Those are based off of European descent people. So they aren't a full picture of health. And there may be people, and there are plenty of people who are in their normal range on the BMI chart, but their cholesterol is through the roof and they have a heart attack and stroke next week. So it's not a full picture of health. Okay? Yes?
Blood sugar, is it just the under 100?
Blood sugar, you don't necessarily just look at the glucose because that just tells me how much sugar is floating around at your body at the time the blood was drawn or the time you pricked your finger. Now this makes a difference if you're on insulin. If you're on insulin, you gotta talk to your doctor because that's why we're pricking and seeing, what your blood sugars are before and after your meal. When you first wake up, that's a whole different picture. But if you're not on insulin, then that's why it's more accurate to look at the hemoglobin A1C because every time we eat a meal, our sugar spikes. Every time we fast, our sugar drops. So we're looking at what your blood sugars look like over the last 3 months to tell us what your actual health risks are when it comes to sugar.
And that sweet spot is 7, right? A1C.
That's a good question too. So guidelines say that once your hemoglobin A1C is over 6.5, that is a diagnosis of diabetes. Now, once you have gotten a hemoglobin A1C over 6.5, you have a diagnosis of type 2 diabetes, it is considered well-controlled diabetes if that is less than 7. I know, see, it's a lot of nuances to it, okay? Excellent questions, you all. So we're gonna leave this part for you all. This is what I go over in my practice. You can screenshot this or take a picture. This is my Inspired Health method. I go over this in depth with my patients individually and with my health coaching. But the thing we're looking at is our nutrition, our stress, our sleep, our physical activity, our intellectual health, our rest and relationships, our environmental health and desires. These again are blanket generalizations, okay? I just had to give you what in general is recommended, but of course you should be personalized. Nutrition-wise, a goal of transitioning towards our nutrition being at least 80% or more primarily whole food plant-based. Okay? A goal, all right, of transitioning towards. Y'all heard those words? Okay, all right, and then stress and sleep, a goal of 7 to 9 hours of consecutive uninterrupted sleep at night, and a good stress management regimen, all right? That can mean a lot of things, but we're given the generalization here. Physical activity, a goal of movement and exercise most days of the week. Okay, there's 7 days in the week. So we know what most days of the week looks like, all right? And we're looking at both movement and exercise. Are we sedentary or do we have movement throughout our day? And scheduled exercise. People tell me all the time, well, I clean for a living. I chase my kids around the house. Well, that's movement, that's one part. But then we also, most days of the week, want scheduled exercise with an emphasis on resistance training, ladies, with an emphasis on resistance training. Cardio should be the second priority, okay? Intellectual health is looking at healthy mindset, motivation, and mood. That can mean a lot of things. This is the generalization. Rest in relationships. Are our relationships healthy? Are we getting good rest? Are we getting relaxation? Environmental health. Is our home environment safe and peaceful? Are we having career satisfaction, desires? Are we fulfilling our life's purpose? Do we know what that is? Is it fulfilling? And what's our overall health rating? So these are what we're looking at, okay? That's the inspired health method. I'm gonna just give you a snapshot of what mine personally looks like, okay? So this box here is for you to fill out. Top 3 ultimate wellness goals in this season of life. So for mine, for example, in this season, I wanna eat a primarily whole food, plant-based nutrition Monday through Friday. I wanna do what I wanna do on Saturday and Sunday. It's called balance, okay? On number 2 is I wanna exercise most days of the week, and I want there to be an emphasis on resistance training. And number 3, I need some quality sleep regimen with at least 6 hours of sleep nightly. Now yours may be more focused on social interaction. Yours may be more focused on self-care. These are just what I'm focused on, top 3 things in this season of my life, okay? And then the next thing I do with my patients is, what are 3 specific, measurable, attainable, realistic, time-based things that I can commit to today for the next 30 days that will help me just transition towards those, okay? What do those look like for you? This is what I want you to fill out on your own, okay? So for me, I'm gonna order my groceries on Saturday. They're gonna come to my house. I'm gonna meal prep them on Sunday. I'm gonna prep lunches and dinners on Sunday. And then I'll just have my lunches and dinners already prepped and ready to go, healthy food. And that way, I'm reaching my goal of that Monday through Friday, primarily a whole food, plant-based nutrition, all right? Number 2 is I have a little home gym, have my Peloton, I have my little TV, I put the Peloton app on, I press 20-minute resistance training. I'm gonna do that at least Monday, Tuesday, and Thursday for at least 20 minutes at 6 a.m. before my kids wake up, okay? And then number 3, I'm gonna get in bed by 10. I'm gonna turn off all devices and screens by 10:30, Monday through Thursday. That's just gonna help promote my healthy sleep quality. So that's just an example. We good? Can you guys do this on your own of what your top 3 ultimate goals are in this season and what 3 specific things you can commit to for the next 30 days? That's our inspired health method. Balance and boundaries. We don't have a whole lot of time for it, but I do want to just tell you quickly what I want you to be able to do on your own with the circles that are intersecting, okay? Because for me, the foundation of balance and boundaries, they're rooted in our values and our why, all right? This is one of my favorite books. I saw they had a quote by Simon Sinek in the last one. Start with Why is one of my favorites. But what are your values? What do you value? What is your why? What is your purpose? What are those? Because everything else we do should be pouring into that. If I say that my why is my family, but then I'm working so much that I don't see my family, then I need to revisit my wellness plan, right? And so this is a busy slide. I want you to just take a picture so you have an example for yourself. I want you all to be able to do this on your own. The left side, I want those where you list out your personal balance and boundaries. What are the things you do for personal balance and boundaries? What are some things, personal things, that have helped you with your balance and boundaries? List those on the left. You see my list here. This is actually mine. So my list is to the left. On the right, what are some things you do for your professional balance and boundaries? What are some things you have done that help with your professional balance and boundaries? If you don't have any, then what are some things you want to do? Put a little star by the things you want to do, okay? But list out the things you're actually doing. That's what I do. And then in the middle, these things can intersect as well. So what are some things that both contribute towards your personal and professional balance and boundaries? Those are mine in the middle, okay? I'll just read those. For me, the things that help lead to that freedom is my outsourcing, my calendar scheduling, my checklist, saying no, delegating, and building a team, okay? Touch, Instagram, if any of you are on Instagram, definitely check me out. I'm on Instagram, is my main social media, but also YouTube, TikTok, Facebook, but mostly Instagram at Dr. Jade MD. Thank you all so much.
Let's give it up again. Interesting. Especially that last one on what I'm not going